It's Wednesday, October 30th, and this is the Daily Medical News, where we bring you clinical medicine's top headlines, as well as an in-depth look at today's biggest story. I'm Terry Rudd.
And I'm Mary Ellen Schneider. Today, there's little evidence backing the use of cannabinoids to treat mental disorders.
A head-to-head matchup of Liraglutide and semaglutide reveals a winner in glycemic control and weight loss.
Severe hypoglycemia and poor glycemic control fuel fracture risk in older patients with type 2 diabetes.
And patients' demeaning behavior takes an emotional toll on doctors.
Plus, a blood test that rivals PET scans at revealing amyloid plaques may be coming to market. But first, help us make this podcast better by completing our short listener survey via the link in the show notes. And now, the news.
There is scant evidence to recommend medical cannabinoids and derivatives such as THC and cannabidiol to patients with depressive disorders, anxiety, or other mental disorders. That's the conclusion from a systemic review and meta-analysis published in The Lancet Psychiatry. Researchers from the University of New South Wales in Sydney analyzed 83 studies with more than 3,000 patients. Patients were treated with a medical cannabinoid for primary or secondary depression, anxiety, ADHD, Tourette syndrome, PTSD, or psychosis. In patients with anxiety in 7 randomized trials, there was very low evidence that pharmaceutical THC, with and without cannabidiol, led to differences in symptoms. In 10 studies with nearly 1,500 patients, a pooled analysis across all mental disorders showed pharmaceutical THC, with and without CBD, didn't improve the primary outcome. And it was associated with significantly increased adverse events compared with placebo. Given the findings, the investigators cautioned that doctors and patients need to understand the risks of cannabinoids and the limits of the existing evidence.
Semaglutide topped liraglutide at reducing hemoglobin A1C levels and body weight in patients with type 2 diabetes. That's the key finding in the Phase 3b SUSTAIN-10 trial, which was presented at the annual meeting of the European Association for the Study of Diabetes. Nearly 11,000 patients with type 2 diabetes were randomized to doses of 1 milligram of semaglutide or 1.2 milligrams of liraglutide. In the study, mean glycated hemoglobin at 30 weeks fell by 1.7% with once-weekly semaglutide and 1% for once-daily liraglutide from the overall baseline level of 8.2%. Mean body weight dropped during the same period by 6 kilograms with semaglutide compared with 2 kilograms with liraglutide from a baseline of 97 kilograms. Semaglutide's manufacturer, Novo Nordisk, sponsored the study.
Patients with type 2 diabetes and poor glycemic control or severe hypoglycemia may be at greater risk for fracture. Researchers at Kyushu University in Fukuoka, Japan, analyzed fracture incidents for more than 4,700 men and postmenopausal women with type 2 diabetes. Patients with a higher risk of fracture included those with 1 or more episodes of severe hypoglycemia. In patients without severe hypoglycemic episodes, those with a baseline hemoglobin A1C level of at least 9% were at greatest risk of fracture. Compared with postmenopausal women, the fracture risk was greatest in men with multiple severe hypoglycemic episodes. The findings appear in the journal Diabetic Medicine. We'll be back after this message with more medical news.
Despite an increasingly diverse workforce, many patients remained biased towards certain physicians, and that can produce substantial negative and occasionally positive effects. That's according to University of California, San Francisco researchers who convened focus groups of 50 physicians. In describing biased and demeaning patient behavior, the participants recalled remarks that ranged from refusal of care to questioning the clinician's role. Remarks also included ethnic jokes, questions as to their ethnic backgrounds, as well as inappropriate flirtations or compliments. Doctors' negative responses to such behavior included carrying an emotional burden and withdrawing from work. There were also positive responses, however, such as an increased desire for self-growth and to pursue leadership opportunities. Deciding how to respond, or to respond at all, was often dictated by the level of support from colleagues, a professional responsibility to peers, and the presence of a positive role model who would have done the same. The study appears in JAMA Internal Medicine.
A blood test that seems almost as good as amyloid PET scanning for detecting asymptomatic amyloid plaques in the brain could be on the market in 2 to 3 years. That's the projection from a report presented at the annual meeting of the American Neurological Association and simultaneously published in Neurology. The blood test measures the plasma ratio of amyloid-beta 42 peptide to amyloid-beta 40 peptide. Amyloid-beta 42 is much stickier, and it's more prone to aggregate in plaques than amyloid-beta 40. The ratio of the two falls as the 42 form is sequestered into amyloid plaques, while the level of amyloid-beta 40 remains more constant. Investigators at Washington University St. Louis studied 158 mostly cognitively normal people in their 60s and 70s. People who had a positive blood test but a negative PET scan were 15 times more likely to convert to a positive scan 4 years later than people with a negative blood test. The researchers say that means the blood test detected the brain changes of Alzheimer's disease before the amyloid PET scan, and they predict it could be used in prevention trials to screen for people likely to be amyloid PET positive and at risk for Alzheimer's disease. The FDA granted the blood test breakthrough status in January 2019. C2N Diagnostics is developing the test, and researchers predict it could be available commercially in 2 to 3 years. Several other companies are also working on similar assays. And that's it for today's Daily Medical News. Be sure to catch the newest episode of the MD Edge Psychcast, available today and every Wednesday. For MD Edge, I'm Terry Rudd.
And I'm Mary Ellen Schneider. Thanks for listening.